Today we have nephrology grand rounds, and we'll be getting a lecture from Dr. Robert Tannenberg, who many of you know is Professor of Medicine and Division of Endocrinology at Brody School of Medicine. He's also the Medical Director of the ECU Diabetes and Obesity Institute and serves as the Director of Clinical Diabetes Fellowship here at ECU. Dr. Tannenberg directs a number of diabetes-related initiatives here at East Carolina University, namely the Diabetes Research Center for Clinical Trials, in which he's been a principal investigator for over 60 research studies. A little bit of background about Dr. Tannenberg, if you don't know, he obtained his medical degree from the University of Illinois in Chicago and completed his medicine residency at the Mayo Clinic in Rochester, Minnesota. Then an endocrine fellowship at the University of Minnesota down the road in Minneapolis. Then was trained in diabetes at the Joslin Diabetes Center, which is up in Boston, Massachusetts. He's formerly on the faculty of Georgetown University School of Medicine and was Director of Diabetes Treatment Center at that institution. He's also a consultant for the NIH for one of the landmark clinical trials known as the Diabetes Control and Complications Trial, or DCCT. Dr. Tannenberg has a special interest in insulin therapy, type 1 diabetes, and the treatment of patients with diabetic neuropathy, severe insulin resistance, and the metabolic syndrome. He has over 100 publications, including articles, book chapters, and abstracts. He's been published in a number of prominent scientific journals, including Diabetes, Metabolism, Endocrine Practice, Diabetes Technology and Therapeutics, Mayo Clinic Proceedings, and the New England Journal of Medicine, to name a few. He's been the endocrinology editor of Hospital Physician and is an editor of Diabetes Health. So we'd like to welcome Dr. Tannenberg.
Get connected here. Thank you. What I'm going to do is talk about inpatient diabetes management. Some of this has to do with outpatient too, but mostly inpatient. And I'm also going to try to focus a little bit about CKD. Hopefully everyone got one of these blue books. Everyone, we pass these out. This is our little inpatient manual for anyone who's doing hospital rounds with diabetes. So please help yourself to one of these books. We also have a couple handouts here, and the slide deck will be on your website. These are my disclosures. So my objectives for this talk, I review the impact of uncontrolled diabetes in the inpatient setting, talk about limitations of traditional sliding scale, and review evidence-based medicine, a sliding scale versus basal bolus, a muscle daily injection, and talk about some alternative forms of therapy. I do have in this deck quite a few slides on IV insulin and the EndoTool, but I thought, since that may not be the most focus for you folks, I'll skip over those, but at the end you want to talk more about how EndoTool works and how IV insulin works, we'd be glad to take that later. But I'm going to focus mostly on sub-Q, as like I said, with several extra slides on CKD. Here. So let's talk about the problem. So if you look at patients admitted to the hospital, this is from Grady Hospital in Atlanta, 38% had hyperglycemia, but of them, only a certain number were known diabetic. A lot of them had so-called new onset hyperglycemia, defined as a fasting greater than 126 or a random glucose over 200. So therefore, if you look, there's really three kinds of patients in the hospital with hyperglycemia: known diabetics, existing but unrecognized diabetic patients, and people with stress hyperglycemia. There's a little figure from the New England Journal 2010 showing how things like glucocorticoid, catechols, can cause cytokines, inflammation. How, of course, we give patients dextrose. They don't eat, they get lipolysis, they get gluconeogenesis, they have insulin resistance. All this leads to hyperglycemia. And on your end, the renal point of view, if they get above renal threshold, they have fluid depletion, hypoperfusion, and electrolyte loss. But also, the molecular end, they have oxidant injury, endothelial dysfunction, neutrophil dysfunction, complement inhibition, protein glycation. All this leads to sepsis and poor wound healing, neuromyopathy. So diabetes itself is the fourth most common comorbid condition, present about 10% of hospital discharges, and about 30% of cardiac surgery patients have hyperglycemia and associated with longer length of stay. So here's a study from Connecticut showing over 2,000 general medicine inpatients. Of this group, 26% were known to be diabetic, and about 3/4 of them were on insulin therapy. They have about a threefold increase in mortality compared to the non-diabetic patients. But the new onset hyperglycemic patients, were 12%, Only 42% received insulin, but they had an 18-fold increase in mortality. So apparently a lot of patients come in with stress hyperglycemia, not recognized and may not be treated, and they end up with greater mortality and morbidity, as we'll see. This is from Crinsley in Connecticut, showing, looking at glucose levels retrospectively over 1,826 patients admitted around the year 2000, and you can see that if the glucose was greater than 300, the mortality was 42% mortality. But if you look at 160 to 180, you still had a threefold increase in mortality compared to glucose of 80. And this is Pierce again showing inpatient mortality, new onset hyperglycemia 16% versus known diabetes 3%, normal glycemia 1.7. By the ICU, new hyperglycemia 31% mortality, and known diabetes, normal glycemia about the same at about 10%. This is from a Vandenberg study showing that people in the ICU, high glucose levels have increased morbidity, sepsis, more need for dialysis, more need for transfusion, and more critical illness, polyneuropathy. So what happens when the blood sugar is high? We know it reduces intravascular volume, they get dehydration, changes electrolytes, white cells don't work well, chemotaxis is poor, complement doesn't work, and wounds don't heal. In fact, if you go back and you Google Nobel Prize speeches, you can pull up every Nobel Prize winning speech ever given. So I went and looked at the 1925 Nobel Prize speech by Dr. Banting. It was about 3 years after he discovered insulin. And he had a lot of data by then. But I think the most interesting thing was, remember, this is like 40 years before antibiotics. Case studies were known of people with previously recalcitrant infections and surgical wounds, such as gangrene, just giving them insulin. It wasn't obviously like we have today. Giving whatever insulin they had, they actually had able to heal wounds. So clearly, the idea of infection being related to high glucose goes back about 90 years. So looking at infection, this is Faneri's data. So Faneri is a heart surgeon in Portland, and he's showing that if you look at glucoses after cardiac surgery, 5,000 patients, as the glucose starts to hit above 180, the incidence of infection occurs. So I used to make rounds at Washington Hospital Center and in Georgetown. We used to see a lot of wound dehiscence post-cath. We almost never have it anymore here at PCMH. We don't have it because all patients who go have heart surgery, first of all, they have an A1C pre-op lab, and second of all, anybody with even the slightest elevation of glucose goes right on the IV insulin. So they immediately put them on IV insulin, and we don't get these types of infections. So I think this is data from Harvard. I think it's very interesting. So a single, again, this cardiac surgery, single post-op glucose of 220 or greater, 6-fold increase in nosocomial infection. And so obviously diabetes leads to longer length of stay, more problems, more complications, more costs. I mentioned leukocyte arising, so this already, glucose control. So a study was done. Carlos Estrada was a general internist here, and he worked with our heart surgeon, did a study, published in Annals of Thoracic Surgery in 2003, looking at our own hospital study after heart surgery, and found, with about 1,500 post-CABG patients, that every 50 milligram increase in glucose added about 3/4 length of stay, and every 50 milligram glucose lowered length of stay about by a day. Increased hospital cost difference about $3,000. The Portland group had about 5,000 patients, had about the same thing. About 50 milligram glucose difference can be like one extra day length of stay. So this happened. I came here in 1998, and they were doing this study, and based on this, our heart surgeons actually initiated the Portland protocol for all the post-op CABG patients, and that's why we ended up trying to start a diabetes program here to see if we can use this kind of therapy for the rest of the hospital to get better results. So there's been a controversy about what's the best control. Now, after heart surgery, that 110 to 140 has been pretty much shown to be pretty good results. In terms of, it's shown, has some evidence base to show that you get better results and outcomes. But there's been concern about patients getting hypoglycemic. And the study was called the Nice Sugar Study, which is a big control study. And what they did is they tried to compare in the ICU patients who had glucoses in this type group with a mean of about 118 to those who had control. But their control group actually was actually very good. The control group actually had about 144. So whereas with the Vandenberg data, the control group were people that had an average close to 180 to 200. And based on this report, you can see from the clinical proceedings, they were saying that 110 to 140 is still good if you can avoid hypoglycemia. So if you compare the Lubin data, the Vandenberg night sugar study, the biggest difference is the patients getting IV insulin in the Lubin study all got calories. They're giving insulin, but they're also giving dextrose, TPN, or 2-feed. And that, I think, is a big difference. These people here did not get it. I think so. If you give insulin, you get calories at the same time. It makes for anabolic state, and you get really good results. This is kind of a J curve showing the people with highest glucose values, mortality. You get above renal threshold, and you see that when you start to get hypoglycemia, you also get. We'll talk a lot about hypoglycemia. So based on current recommendations from the ADA, American Association Improvement Trials, and the Hospital Association, Society of Hospital Medicine, we still kind of recommend today in post-CABG state, in some of the ICUs, 110 to 140, other units like 140 to 180. So what we do in our hospital, I've asked every director of every unit to tell me what they want for their target for what. So Dr. Mazer wants 140 180, then he gets it. So within reason, so we have different, basically, target glucoses for different units. And if we're using an IV insulin program, of course, that's the target the IV works at. And you know when you do your computerized order entry, the targets are also right there. So this just shows you the 140 to 180. It's probably the best for most people. And so the definition of hypoglycemia would be less than 7. So again, there's some controversy about that, but part of it has to do with the fact that the weak link in the whole deal is glucose monitor. Because the glucose monitor and the finger stick are not that accurate. The units where they can take some A-line blood works better, and the machines that they have are not as accurate for some whole range. So if we could get better sensors and meters, we wouldn't have to worry about the hypoglycemia. But right now, we still are stuck with our finger stick test. So this is the ADA algorithm from 2006 about what to do in the hospital. Basically, when a patient comes in the hospital with diabetes, oral agents are not recommended. We can talk about that if you want. Insulin is recommended. And then when they're sick, they belong to the ICU IV insulin. If they're healthier, they can go on sub-Q insulin. And sub-Q, now I'll talk in quite a bit of detail about basal bolus versus not using the sliding scale. So why is insulin good in the hospital? Because it's the only drug we know that can always control blood sugar. Oral agents are not really good in the hospital. And you have a sick patient, I don't care whether they're at home, in a hospital, you're diabetic, you got to put on it. So I think there's good data to support this. And remember, when you give insulin IV, by the way, you have total control. So when you turn the IV off, half-life insulin, 4 to 5 minutes. So 15, 20 minutes are out of insulin. That's why when you get someone in DKA or something, type 1 patient, you've got to give the sub-Q 2 hours before you turn the grip off. So that's an important point. So you have better control with IV insulin than you do with sub-Q. There's a lot of problems with sub-Q absorption. And that's why it's so hard to treat diabetes properly. So this is the last thing I want to talk about IV, and then we're going to go to sub-Q. And to know who should be on IV, who should get IV insulin, CKA, hyperosmolar state. And you know your patient, the CKD population, I don't know if you realize, but their blood sugars go up much faster than people with normal kidney function. Because if you have normal kidney function, your blood sugar goes up, you can pee it all out. You can pee a lot of calories out. As long as you're drinking fluid, you can keep your blood sugar pretty well controlled. But once you have kidney problems, if you don't pee that glucose out, and then of course the blood sugar goes up much faster. The highest I've seen is 2200, patient with some mild CKD, but it can go up very, very high. And that's why typically hyperosmolar patients have higher blood sugars than DKA patients. So here's some other reasons to give it. Type 1 patients, the L&D. And one of the things that drives our service is steroids. Everybody on high-dose steroids usually ends up with endocrine consult. There's so many of these people will have very, very severe high blood sugar. So let's talk a little bit about some CKD-related issues. So what is some of the problems? Well, there's increased risk of both hyperglycemia and hypoglycemia. And so, first of all, you know that insulin is metabolized to a great extent by the kidney and the liver. And as your kidneys start to fail, the insulin hangs around a lot longer. A lot longer. So if they say Lantus is 24 hours, or Myers is 24 hours, it could be 30, 36 or 40 hours. If they say, you know, the Lispro insulin is 4 to 6 hours, it could be 8 hours. So you have to remember that any insulin you give is going to last longer. So that's why analogs, short-acting analogs, are better than regular insulin because of how long it lasts. In addition, you know that the kidney has glycogen in it, and that's a source of calories. So if your kidneys aren't working, you can't store glycogen. So again, if you're not eating, you're more prone to having hypoglycemia as well. It's another reason. I've got more to show you on that. And we'll talk about the A1C in a little bit. But, well, there are two things that in renal failure. Basically, some things will raise the A1C, but most of the things like erythropoietin and people with anemia, they may decrease the A1C. So actually, this is an A1C graph, and this is looking at 23,000 people on hemodialysis. And you can see that 24% had A1C less than 6%. A lot of them are less than 5%. And this article, by the way, all the references that I used for the CKD are on your handout. I put them on the handout for you. Shows that when the A1C is less than 5%, the mortality is increased. So basically, your A1C is between 6 and 8 is probably a better place to be than to have people down that low. Now, there may be other reasons for that we'll talk about. So actually, I found this article recently, and it showed you can actually do a calculation. So for example, if the patient's hematocrit is less than 30%, to get a proper A1C, you would multiply 1.14. If there's less than 30% they're in low-dose EPO, you multiply 1.19. If they're less than 30% high-dose EPO, 1.38. So there's at least one person who's trying to correct the A1C for hematocrit and EPO. So there's a term, about 1 out of 3 people with diabetes, and mostly we're talking about type 2 here primarily, end up getting the so-called burnt out diabetes, where they get kidney failure. So basically the diabetes is going to go away. Good news is no more diabetes, right? The bad news, you're on dialysis. So not a very good trade-off. So what are the reasons that people get this so-called burnt out diabetes? Decreased renal clearance of insulin, and they have decreased hepatic clearance, presumably from the uremic toxins, because this can be reversed with dialysis. Impaired renal insulin degradation, decreased half-life, decline in renal gluconeogenesis, we mentioned that, deficient catecholamic release, and other things, other factors in urine on glucose homeostasis, and of course diminished food intake because of anorexia, gastroparesis, and so forth. And there's protein wasting. You have this malnutrition, inflammation complex, you have loss of body weight, fat mass, comorbid conditions, and a lot of patients become hypoglycemic during dialysis, as you know. Peritoneal dialysis, when they use that high dextrose stuff, can really cause problems. It make people very, very hyperglycemic when they use the higher dextrose. I forget the percent, you know. So, and then medications, dietary restrictions, and the A1C may be confounded, as mentioned. So, so insulin is recommended for advanced CKD when you need something, but here's some interesting data. And this comes from this article in Seminars of Dialysis. That when the GFR is between 10 and 50, you probably need to reduce the dose by at least 25%. When the GFR is under 10, reduce it another 50%. But once you start dialysis, actually sometimes the patients, they actually improve their insulin resistance. So part of it, when you're in renal disease, you actually have insulin. A non-diabetic may become someone insulin resistant, so as opposed to the burnt out diabetes. So you're kind of balancing 2 different things. And then, of course, if the patient's eating or not makes a huge, big difference. And I'm going to tell you why this is important. So some of the causes that in the textbooks for hypoglycemia are new NPO status, vomiting, interruption of IVs, TPNs, tube feeds, dialysis, reduction of steroids, and medication. And inpatient treatment, I think you understand how we treat hypoglycemia. We use dextrose here for most people. It's kind of the rule of 15. If they're going to eat, give 15 grams of carbohydrate, repeat 15 minutes later, so forth. And of course, the best way to prevent is to prevent it in the first place. And we're going to try to focus on that using basal bolus, IV insulin possible, and using good common sense things. So we did a little survey here. Sandra Hardy, Dr. Hardy, and our case manager team, we've looked at 10 hospital units. Here they are: 3 south, 3 west, 3 east, 2 south, 2 east, 1 west, MIU, CIU, CVIU, and bariatric surgery. And these were mostly substitute insulin used. And we looked at all glucose values below 70 from meter downwards. So some patients could be on there more than once. And so we found in the 10-month period about 150, just in these 10 units alone, about 150 episodes of hypoglycemia in a month. So the number one cause, 36%, was excessive insulin dosing. Physicians were writing for doses that were too much for various reasons. They gave the home dose, now the patient's not eating, maybe the patient was on steroids, they're stopped with that. But the number two cause was CKD. 28% of all hypoglycemia in these 10 units was CKD. And 12% of these people, not of the 20, but 12% of the total value were people on hemodialysis. So this sort of say, maybe this is some low-hanging fruit, we can make some changes. And I talked to Dr. Cristiano about it. Maybe we can do something to try to help reduce some of this hypoglycemia because, as you know, insulin is the most dangerous drug anybody prescribes. So we want to try to reduce hypoglycemia. Here's a few others just to show you. New NPO status. New NPO status 8%. Sulfonylureas, which really should be given, especially in your patients, 7%. Insulin driven 7%. So how do you treat patients with sub-Q insulin? So we talked a little bit about Banting Best. Here he is. There's a little dog. So I injected the dog with insulin. Great story. I read the story, one of the story. And so back then, doing blood sugar was very difficult. So instead, they came up with urine sugar testing. When I started practicing in the 70s, that's all we had. Until the 1980s, we didn't even have finger stick testing. People at the Joslin, they would do ear blood sugars, things like that, but no one had home testing. And so actually, if you look at the Joslin textbook, 1934 recommended giving extra insulin based on urine glucose. I mean, it sounds stupid. You know the renal threshold varies. You know this can be hours later. People double void their urine. But that's all we have. So what happened was, when finger stick testing started to come widespread in the hospitals in the 80s, people said, we'll do a sliding scale based on finger stick testing. And what's the main advantage? The main advantage is the house officer writes for sliding scale and forgets about the patient. That's it. That's the only advantage. It's never been shown to anything else. Not based on pathophysiology, not weight-based. It's just to just get rid of the patient and not worry about it. And so typically people come in, they're NPO, and they're put on sliding scale. You've probably seen this all before, 2, 4, 6, 8, 10. I don't care if you're 90 pounds or 400, we get the same sliding scale, right? You've seen this, okay. So we're going to get to this. So keep in mind that for over 400 is 10 units, and this is 4 units for 250. We're going to show you 2 cases. So sliding scales, first of all, are after the fact. You're trying just to correct. Not that you shouldn't correct when you're high, but it doesn't anticipate why you might be high in the first place. So a lot of patients, I saw 2 type 1 diabetics around this weekend, and this one young lady, she's been in DK about every month she comes in. Got sickle cell, got DK, she's always in, and what she does is if her blood sugar is under 100, she takes no insulin even though she eats. So, well, this is the way she was taught, so then she doesn't eat. Then she goes, the next blood sugar is going to be high. So she's a type 1 diabetic. Everyone, type 1 and type 2, their blood sugar goes up when they eat, but especially she does, being a type 1 patient. So it's after the fact. It doesn't take into consideration what you eat, how you eat, what your requirements are. It doesn't consider body weight, sepsis, or any steroids or anything. And it doesn't provide basal insulin. All people make insulin. So even if you're fasting and non-diabetic, your insulin is like 5 to 10. You always have insulin. So when you eat a meal, it might go up to 50, 60, or 70. And then it shuts right back down again in 2 hours. So people need to have basal insulin, they have to have mealtime insulin. And this is not actually happening. So you're not giving basal insulin. As a result, you have increased hyper and hypo. So, and of course, sliding scale with regular insulin is even worse because you can have stacking of insulin and make it very low, but generally it doesn't work very well. We sometimes use regular insulin every 6 hours for people that are on, along with basal. We occasionally do that. But normally when we give insulin, we use analog insulin with basal. So here's a couple of studies. One from Johns Hopkins in 1997, and they looked at people on sliding scales. And this is what they found, that the people that came in the hospital, and they looked at how many people had a blood sugar over 300, 170 patients, and the people with sliding scales had a lot more hyperglycemia than people who just went on their usual dose for their medication from home. So it was actually worse. Here's a DKA study. Sliding scale did the worst again. So, and I'll go to a comparison a randomized control trial. But let's talk about physiological. What's the physiological way of giving insulin? And I'll make another pitch not to use oral agents in the hospital. That being said, I would say that as if you have some spiking with meals, you may actually get by with a DPP-4 inhibitor. A new one just came out. I have to, tell you, it has an advantage from linagliptin because it's all GI free. So you don't have to worry about the crap. The other drugs, the sitagliptin and saxagliptin, you can still give in the hospital. In fact, we've been keeping people on sitagliptin of 25 a day in their dialysis. You can adjust them. So this may have some advantage. But otherwise, I don't see any advantage for that. But sulfonylurea is bad again. PCBs don't work very quickly, cause fluid retention. Metformin can cause lactic acidosis. So, and those orally, you can overcome insulin resistance from high-dose steroids or increased calories with CKD. So, generally, basically, you don't use orally. The Society of Hospital Medicine, same recommendation as American Medical Association, not to use orally. That being said, we occasionally will have people in rehab or psychiatry, people that are ready to go home and make occasional because when they're sick in the hospital, to stop orally. So you've seen this algorithm. This is a type 2 diabetes algorithm. They start metformin, lifestyle, all this stuff, etc., etc. And this, of course, is it's an outpatient. I've seen people into this hospital give them one shot of insulin, send them on metformin, even though their A1C is like it. Doesn't make any sense. Half. So if you're a patient in the hospital, you don't follow this algorithm. This is an outpatient algorithm. And when this algorithm was published in 2009, it had a very important caveat. Dr. Nathan, who gave a talk there, we had him on a speaker here a few years ago, he went over this because he was one of the authors of the algorithm. And that is, if a patient's blood sugar is over 250 randomly, or fasting over 250, randomly over 300, A1C over 10, ketone symptomatic, forget the algorithm, go right to insulin. That is the recommendation in patients in the outpatient setting. When patients are hospitalized for acute illness, forget the algorithm, start insulin as soon as possible, and use IV or sub-Q, but don't use sliding scale. So this is the most important slide in all diabetes. That is the non-diabetic insulin profile. So as I was mentioning, if you haven't eaten lunch right now, your insulin level is probably here. If you just had a big lunch, it might be over here. But this turns on and off at a minute notice. And that's what you know. So people say, well, you give thyroid hormone, they don't have complications when they take it. Why do people with insulin have complications? Because insulin, number one, doesn't absorb well subcutaneously. There's a lot of nuances to that. Number two is insulin has to be regulated on a minute-by-minute basis. So if people don't understand this, if they understood it, it'd be better. Now, if you just try giving basal insulin, what happens is you still don't take care of these people, then you end up having hypoglycemia when you're not supposed to have it. That's an issue with that. So here's your basal insulin here. And this is bolus. So basal is keep you from the liver dumping out glycogen into glucose or gluconeogenesis, keep the fat, break it down into fat cells. But bolus insulin is for the meal. Again, basal insulin to meet metabolic requirements. Prandial and supplemental or correctional are the two ways to give bolus insulin. Prandial to cover meals, of course, and correctional if patients have unexpected hyperglycemia. The basal concept is to give insulin required when patients are basically fasting, suppress glucose production between meals, suppress hepatic glycogenolysis, and if they're type 1, suppress lipolysis. You know, insulin is the only anti-glycolytic hormone. So generally it's about 50% of need, but it may be more in the hospitalized patient. And these are your basal insulins. We Xerox for you here, prescriber's letter, which I think is the best objective thing around. And it has on all the diabetic medications, including the new ones, and it has all the insulin. So these durations of action are not mine. It came from the prescriber's letter, which is very objective. So I'm referring to that, showing different basal insulin. So here, if you take Largine, for example, and you try to raise the dose, you see what happens is, and this is what, so the primary care doctors, first of all, their biggest problem is on when to start insulin. Now they feel more comfortable with pens and basal insulin. They're starting people on Largine or Levemir. However, what happens is then they don't get control. They know what to do, and then they end up going to pre-mixed insulin or whatever. But you see, the problem is you have to take care of yours. And that's where the bolus comes in, or the prandial insulin. Basically insulin for meals and insulin for corrections. And here are your bolus insulin. So we used to, as you know, we used to have Aspart or Novolog in our hospital. We just changed last year to Humalog or Lispro. It was just for reason of cost. Otherwise, the insulins are identical. They basically work the same, as does the Pedro and lysine. All these three insulins, as opposed to the basal, there's a lot more differences between the different basals. But the prandials or bolus insulins are pretty much the same. And regular insulin, again, is used in IVs, for IV drips, and you can use it in the hospital, but it's not going to, in your patient population, I think it's better not to be used. So here's a patient who you want to control with the standard insulin, the Walmart brand, if you will, regular each meal and NPH at bedtime, NPH twice a day. You see what happens is you don't have enough insulin to cover meals, then you end up having too much insulin between meals or at bedtime. So if you use the analogs, it's better. Still not perfect. A pump is better than that, but even a pump has problems. When I was in DC, we did a study, a big trial, we put in 10 implantable insulin pumps, but the insulin actually went in the peritoneal cavity with a catheter, just like you do peritoneal dialysis. And their A1T was the best, there at least fluctuation. But unfortunately, for different reasons, that pump never came to fruition in this country at all. There are about 4 people that still fly to Paris with their pump refill every 3 months. One of my 4 patients. So, but actually, peritoneal insulin works very, very well because it goes right to the liver, where normally it's supposed to go. So in the hospital setting, we've got basal insulin. We need to cover meals and then supplemental or stress. Susan Braithwaite used to be at UNC, came up with this kind of diagram showing here a healthy, sick, and sick patient on calories. And you see the basal is the same. And the sick person has similar amount of prandial, but needs more correction because they're high because of stress. From cytokines, glucocorticoids, things like that, catecholamines. So it needs more correction, more stress. But then you take that sick person, put them on a tube feed, the TPN, and then you need even more insulin. Again, basal and prandial. So there's how do you take care of tube feeds? Well, tube feeds, they're really hyperglycemic, are going to have an insulin drip. You can't use an insulin drip, you can use sub-Q, but you may have to use a basal every 12 or 24 hours. You have to use supplemental regular every 6 hours. But keep in mind, when you put insulin sub-Q on board and that drip, they pull the tube out, or it comes out, and you've got insulin on board, and then you're in trouble. That's why the drips are certainly better. Now, when you have a person on TPN, you can put insulin in the bag, and that sometimes works, but sometimes that's not enough for them. But non-diabetics, they put a little bit, or mild diabetic patients, and stress hyperglycemic patients, you can put in the bag, and that may be enough. So let's talk about different options. So there's a very smart guy named Paul Davidson, who I know in Atlanta. And it was known that a 70-kilogram person who took 50 units of insulin a day, that 1 unit of insulin dropped the blood sugar about 30 milligrams. So, well, if you're taking 50 and one drops to 30, maybe you've taken 30, if you take 30, one drop to 50. And then, well, that kind of makes sense, because obviously the less insulin you take, the more sensitive you are. The more you take, the more resistant you are. So we kind of multiplied 30 by 50, came up with 1,500, like pi, constant. And he came up with this 1,500 rule. Very smart thing, very clever thing, and it actually works. Now there are nuances in the 1,700 rule, 1,800 rule, but there are nuances, and it really does work, and I'll show you how it works in a minute. And he published this in his book, and I forgot much credit for it, but here's the concept. So if you're on 50 units, 1 unit drops you 30. If you're on 10 units, that's your total daily dose, 1 unit's going to drop you 150. If you're on 150 units, 1 unit drops you 10. So this kind of concept is the whole idea of the insulin sensitivity factor. So the more insulin you're on, the more resistant you are to the insulin. The less you're on, the more sensitive you are. If you're a patient with CKD, a lot of them are very insulin sensitive. So here's the concept. You want to correct somebody. You have, say, if this is your actual blood sugar BG, and Y is your target, whatever that is, 100, 120, in this case here it's 100, and then you have the sensitivity factor. So for example, this patient takes 60 units a day, and we decide 100 is the target, you can make the target you want, and the blood sugar is 160. So that means 160, so if you take the 60 units at 1,500, that means 1 unit drops the blood sugar 25 points. So if you want to get from 160 to 100, you divide by 25, you need about 2.5 units, and you would round down to 2. That is the basic concept. And that is a supplemental correction dose. Is a current blood sugar minus whatever target you want. divided by the sensitivity factor. Let's say a patient's new to diabetes. They have never been on insulin. What do you do then? What we do then is we take 0.5 times their weight in kilos and use that as a total daily dose. So let's say a 100 kilogram person, then your total daily dose is 50, and so 50 units, that would be 1 unit drops to 30. Now this is approximation, it's not perfect, and you have to adjust it, but it's a very good concept in general. A lot better than the sliding scale. So again, here's the factor, so skip this one. Another case, so if 250 is your blood sugar, your target's 100, sensitivity factor is 30, then 250 minus 100 will be 150 by 30, you need about 5 units of insulin to correct and bring that blood sugar down. So let's you have these two cases. These are two real cases from PCMH that Chris Dew was treating about 8 years ago. The first patient had a blood sugar of 265, was on 192 units for 24 hours of IV insulin. The second patient we'll talk about had a blood sugar of 412, and their outpatient insulin regimen was 17 units. So in the first case, patient number 1, glucose is 265. So if you say he's on 192 units a day, that's what's required on the IV, right? You want to convert it to sub-Q, you lower sugar from 265, 192 into 1500 means that 1 is only drop about 8. That's all. So if you want to bring them down from 265 to 100, 120, 150, 8 units isn't going to do it. But that's what the sliding scale says, 8 units. In fact, the patient dropped to 234. So in this case, big deal. Like peeing in the ocean here. Didn't work because this patient's very resistant. It's very insignificant amount. So as bad as this is, so what does the patient need? Well, he takes the 7.8, divide that into the difference, he needs about 20 units to bring that blood sugar down because the patient has a high requirement. So that's just ineffective. This next case, and so patients who weigh a lot, who use a lot of insulin, are going to be like the situation. But your patient may be more like this little lady. She's taking glargine 8 units and Lispro 3 that she needs only 17 units. She comes to the hospital. Okay, blood sugar is 412. So let's calculate. So divide the 17 units into 1500. That means 1 unit of insulin drops the blood sugar 80 points. Right? Our blood sugar is 412. What does the sliding scale say for that? 10 units, right? 10 times 88. Anybody do math? Right? That's 880. That should lead to a negative glucose, right? Right? What you really need is 3.5 units. Do math. That would be right. But that she got the 10 units. And guess what? After 2 amps of D50, your blood sugar was still 14. Laugh, but this is going on all the time. So we don't want this, right? This is bad. So this is the situation. So what can we do? We have to try to come up with a more sensible way to correct the fact. So when you're looking at patients on multiple shots of insulin, keep in mind the basal insulin, whether you take it in the morning or bedtime, usually that will tell you what the fasting blood sugar is. That's what you determine the fasting blood sugar. The lunch sugar is determined by your breakfast insulin and your supper blood sugar by your lunch insulin and your bedtime by your supper. So there's a study that Ampierre's did over in Emory. What he did is he compared people with sliding scale versus basal bolus, and he used 24 to 25 units per kilogram basal bolus, and he used glycine to that response trial, and glargine. These were all people who were type 2, remember, on insulin before, and the people in the conventional group he used a paper protocol sliding scale with 3 columns, sensitive, usual, and resistant. So he used a little more sophisticated plain old scale. And if you look at compare the sliding scale to the glargine glycine, you see by the second day, people on basal bolus had their blood sugar through the carbs range. And these people took about 7 days. Not only that, there were some people whose sugar was so high they had to rescue them and put them on the basal bolus. So clearly, the people on basal bolus did better. Now, how much insulin did they get? Take a look. Well, the people on the sliding scale only got about 12 units. You say, well, Hanover, 42 units. Any idiot knows that you can get better control with 42 units than 12 units, but that's what the sliding scales do in some cases, like the case that gentleman and I. So basically, the conclusion of the study was that a sliding scale with a single insulin regimen should not be used for type 2 patients in a non-ICU setting. So here's some summaries about this. And basically, that's still being used. And we've basically, what we've done in our facility here, with computerized records, we've been able to kind of get rid of sliding scale because it's very hard to do it now. Try to do it. It's difficult. it kind of made it almost impossible to do. So we've been pretty successful. There are a few holdout positions here, but I think we've got most of them under control, but we're trying. So basically, these are just quotes saying sliding scale has more problems, and you should use basal bolus for patients. And this is the ADA recommendation, technical review. For patients with intermittent nutritional intake, they should use basal prandial. And that's what we recommend. I like this quote the best. The traditional sliding scale insulin recommends use of this for regular without intermediate or long acting have been shown to be ineffective at best and dangerous at worst. But yet, if you go to all the community hospitals in Eastern North Carolina, I guarantee you they're almost all still using sliding scale. And what happens, we get new doctors coming here, or hospitalists, or new fellows come here, and they train elsewhere, and they want to write a sliding scale, and they find out you can't write it. So that's one job that Dr. Hardy has, to try to work with new doctors, teach them how to use it, and that's the whole point of this book. And by the way, this book is also available in PDF version if you want to download it on your little smartphone. Let's go back to this recommendation here. We've gone through this. Any diabetic patient, no oral agents, insulin, ICU patient, IV insulin, most floor patients use sub-Q insulin. Now, some of the floors you can use IV, by the way, and if you can use IV, you're always better off with IV than sub-Q. Now, we use sub-Q, we talk about basal bolus or sliding scale. Here's a few quotes from 1924. I think they're still good today. This is a remedy that the patient can learn to administer himself, primarily for the wise, not the foolish. It requires brains to live long with diabetes, but to use it successfully requires more brains. So this hasn't really changed since 1924. So I'll take some questions, do some acknowledgments, and we can talk. I have the slides on the intro if you want to cover that, we can.